And I want to welcome you in Bratislava because it's my hometown, and I'm happy that you're here. And I was asked to give a lecture on the diagnostic algorithm of NAFLD and NASH, and I think my predecessor with this excellent state-of-the-art lecture already touched some of the subjects. But I will proceed on the practical management. So, as he said, if you go to work on Monday, you will meet a patient, and that's how we proceed in our practice. So I'm going to touch upon the screening of NAFLD, which was already touched. I'm going to touch upon the diagnosis of NAFLD and NASH, fibrosis, and cirrhosis. So it was already mentioned that according to the EASL and European Association of the Diabetes guidelines, metabolic syndrome should be the diagnosis that we should look in these patients for the presence of liver fat. So it has been agreed that all patients with abdominal obesity, arterial hypertension, type 2 diabetes should be screened for NAFLD, and vice versa. If we accidentally find on the imaging studies some steatosis, that it should also lead us to screen for the metabolic risk factors. There are some other conditions that I think it is reasonable to look for liver fat, and it is the sleep apnea syndrome and polycystic ovary syndrome and probably many more. So in these conditions also we should be aware and maybe look for fat in the liver. So how do we diagnose fatty liver disease? Well, there should be evidence of fat in the liver. That's the first step. The second step, of course, is the diagnosis of exclusion. So there should be no evidence of excessive alcohol. There should be exclusion. We should exclude all the secondary causes of liver steatosis. And of course, we should also look for other liver diseases that may be coexisting with liver fat. So by definition, liver steatosis is more than 5% of hepatocytes that are fatty. And according to the guidelines, magnetic resonance imaging is considered the gold standard. Because there is a chemical signature, hydrogen protons are behaving differently in the magnetic field when they are in water and when they are in fat. So this serves for the diagnosis of fatty liver in magnetic resonance. Of course, we don't do magnetic resonance in real clinical practice in all patients, and we should rely on the liver ultrasound. We should understand that liver ultrasound has some limitations. Of course, 20–30% of hepatocytes can be detected, not less. But it is very good for assessing also for other organs and other diseases in these patients. And of course, we have a lot of non-invasive models for steatosis that have been summarized in many studies. To mention just a few, fatty liver index or visceral adiposity index and so on, and they can be used to detect any type of steatosis or significant steatosis, the grade 1. And we can also use the FibroScan machines to use the controlled attenuation parameter to give us some estimation of steatosis. So to summarize, we have many modalities to look for liver fat. Of course, the so-called gold standard is probably liver biopsy, but we never perform liver biopsy to look for fat. How do we exclude alcohol consumption? By definition, it was already said, female patients should not drink more than 20 grams per day, and male patients not more than 30 grams per day. And of course, we should also ask for binge drinking, which is a phenomenon of late years, and they're defined by drinking a lot of alcohol in 2 hours. In males, 5 drinks, and in females, 4 drinks. So even binge drinking can be a risk factor. Of course, we should also rely on medical history, objective history, and there are some tools to look for alcohol consumption, such as audit questionnaire, CAGE questionnaire, to discover unnoticed alcohol dependence. And of course, we have some labs that we look for. We can use basic labs, but also some other more sophisticated, like carbohydrate deficient transferrin or urinary glucuronide. There are some other models that have been developed. For example, this one that can be used if we're not sure if the patient is having alcohol problems. We can use, for example, this model which uses AST-ALT ratio and mean cell volume, gender, and the BMI. Then the next step is to exclude secondary causes of liver steatosis. We have heard already The main causes are, of course, in patients, drugs such as amiodarone, methotrexate, or steroids, and many more. There are some genetic disorders or severe weight loss, jejunal ileal bypass, industrial toxins, which are a very common cause of steatosis in this country, and well, some endocrine diseases which are not that uncommon, and mainly hypothyroidism or hypopituitarism. And of course, we have heard on the cholesterol ester storage diseases and many other hereditary conditions. And the last step, we should also look for other causes of liver disease, namely in patients that have elevated ALTs for longer than 4 to 6 months. And we should, of course, look for hepatitis C, which can be presented with steatosis. We should look for Wilson's disease and any other inflammatory liver conditions, or basically the whole textbook of liver disease. How about diagnosing NASH? I think it is more complicated because to date, the gold standard for diagnosing steatohepatitis is still considered the liver histology. We are scoring for NAS score or for other scores that have been developed. And the non-invasive diagnosis, there are some models such as cytokeratin 18 and FAS markers of apoptosis, but they have not been used in clinical practice. The histological score comprises of the score for steatosis, the score for lobular inflammation, and the score for hepatocyte ballooning. And if we sum up the score, we have the NASH group, the NASH CRN group classification. And when we have more than 5 to 8 points, we can consider the biopsy as compatible with NASH. There is some borderline. And then if the patient has 0 to 2 points, we can consider that there is no NASH. There is another algorithm that has been developed by the FLIP consortium that also uses the same markers, the steatosis, ballooning, and lobular inflammation. And I think it's the ballooning that decides whether it is NASH or it's pure steatosis. The next topic, which is probably the most important, is to look for liver fibrosis. Why we look for fibrosis? Well, we know that fibrosis is a prognostic factor, and the gold standard has been the liver biopsy, although we know that, of course, the liver biopsy is not a perfect standard because there's a lot of sampling error, it is invasive and maybe expensive and painful. Here are some stages for liver fibrosis. They are generally staged to 4 stages. From 0 to 4, and from 0 to 2, we are talking about mild fibrosis, and when we have bridging fibrosis or cirrhosis, we are talking about advanced fibrosis. So if we have a liver biopsy and we have a patient with fibrosis more than grade 2, it is an independent prognostic factor for survival. And it has been shown by many studies, for example, this one, on several thousand of patients. So to have the non-invasive diagnosis of liver fibrosis, there have been also many studies looking for markers of severe advanced fibrosis. And I have just pointed out a few of them. Well, for example, the FIB4, which looks to have a good positive predictive value. That's about 85%. And then the Mayo Clinic developed an NAFLD fibrosis score, which has an 86% negative predictive value. So these stats can be used even when we are talking to the patient. You can put these markers into the computer and have the result. And of course, there are other tests. For example, ELF test. It depends on how much money you want to spend on the diagnosis. There are the French models such as Fibro test and Fibrometer and many more. Here is an example of an NAFLD fibrosis score, which is an online calculator that can be used, and we get a score, and the score tells us about the probability of severe fibrosis. And well, this is the FIB4 score, which is also used the similar way. Well, the modern machines that are becoming available even in this country are elastography, either transient elastography or shear wave elastography. They have a high negative predictive value, and their positive predictive value is average, so they are very good in excluding severe fibrosis. In confirming mild fibrosis, they're not so good. And of course, the last couple of years, there were studies on MRI elastography, which are promising, and they're showing that they may be more accurate than the transient elastography. And then how about diagnosing cirrhosis? I think it is quite straightforward in decompensated cirrhotics, or when there are clear signs of dysmorphic liver or esophageal varices. And of course, from the non-invasive markers, I have pointed out the MRI elastography or transient elastography, which are very good in diagnosing cirrhosis in NASH. Now, I have been asked to give an algorithm, so I will like to sum up with this slide. On the left side of the slide is the diagnosis of NAFLD. So we start with screening, we start with detection of fat in the liver, and then we have to exclude, of course, many conditions such as alcoholic liver disease, secondary causes of liver steatosis, and exclude chronic liver diseases. And once we have a diagnosis of NASH, of course, we should focus. We have heard how prevalent is severe fibrosis, so we should focus on every patient on excluding advanced fibrosis. And if the patient has risk factors and we cannot exclude advanced fibrosis, we may proceed to liver biopsy to confirm and to give the right management. I would like to thank you and welcome to Bratislava. Enjoy your meeting. Thank you.